to me. My knowledge about it was rather primordial up until a couple of years ago when I met Richard and took a deeper dive into the subject. And I suspect that many in the audience are in a very similar position. So I wanted to start this grand rounds by posing a very simple question, which is, what is cardio-oncology and why is it relevant to us? So there were an astounding 17 million cancer survivors in the US in 2019, and that number is only expected to grow, exceeding 22 million by 2030. This is basically, even if you're not in cardio-oncology, you're going to be seeing these patients in your clinic. There is complex interplay between cancer and its therapies with cardiovascular disease, including shared risk factors between the two disease processes. And I'll highlight some of that. Cardio-oncology addresses the cardiovascular needs of patients throughout their journey through the cancer process, from the time of their diagnosis, before, in terms of risk assessment, during their therapies, and after in long-term survivorship patients. The penultimate goal of cardio-oncology is to provide optimum cancer therapy all the while minimizing adverse cardiovascular outcomes. That is a common goal to cardiologists, oncologists, and cardio-oncologists. So in some of our shared clinics that we have with Richard and Marta, Monica, we all see cardio-oncology patients, and some of the most common reasons for referral to cardio-oncology are highlighted here, where before they start cancer therapy, they get referred to us because of baseline elevated cardiovascular risk, or if they have higher cancer therapy related risk, like getting high radiation to the heart or having high dose anthracycline treatment. As they're going through their cancer therapy, very similar to before, we also get the referral for patients who, again, have pre-existing cardiovascular disease, or if cardiovascular disease is an ongoing complication of cancer therapy. And finally, after they finish their cancer therapy, again, the number one reason for why we get these patient referrals is because of pre-existing cardiovascular disease, but also to monitor for long-term complications of cancer therapy, which can present within a few months of finishing treatment versus a few decades down the road. I want to present a patient that I saw in clinic recently. This is a 56-year-old woman with history of hypertension and obesity. She has no toxic habits, no family history of heart disease, who self-palpated a lump in her right breast in December 2019. She underwent imaging and finally had a biopsy in January 2020, which showed invasive breast cancer that was PR negative, estrogen receptor positive, and HER2 positive. She got a few opinions from Seattle Cancer Care Alliance and a few other oncology providers and decided on a treatment plan. And she decided to go ahead with neoadjuvant chemotherapy before getting mastectomy. So at baseline, her echo showed EF of 66% with a global longitudinal strain of negative 16%, which is abnormal at baseline, but with a caveat that her images were suboptimal, her endocardial definition was suboptimal. So taking that GLS number with a little bit of a grain of salt. Regardless, that was her baseline echo. She received anthracycline 4 doses for a total of 240 milligrams per meter squared. And the plan was to do sequential treatment with trastuzumab. And soon after she started trastuzumab, the repeat echo showed a dramatic decline in her EF, down to 47%, and a mild decrease in GLS from negative 16% now to negative 13%. And it was at this point that she was referred to me, and I got to meet her. And we'll circle back to this patient at the end, but needless to say, I did start her on carvedilol and ARB, losartan. So for the rest of the talk, this is an outline that I'm gonna follow in 5 parts. First is gonna be talking about prevalence and risk of cardiovascular disease in cancer patients, how we do surveillance and assessment of cardiotoxicity from some of these therapies that are used, management strategies for these patients, and a very brief overview of current guidelines that exist on this subject. And we'll review some future directions where the field is going. So talking about prevalence and risk of cardiovascular disease. There's this study from 2016 by Saur Armenian and his group down in Southern California. They reviewed patients from the Kaiser Southern California SEER registry. This is a retrospective cohort study. And these patients were all diagnosed with cancer at age 40 or later, so adult onset cancer. And they were at least 2 years out from their diagnosis. And they compared the cancer survivors with the non-cancer controls. And after adjusting for cardiovascular risk factors, they find that breast cancer, lung cancer, multiple myeloma, and non-Hodgkin's lymphoma in particular had increased incidence of cardiovascular disease as they went on in life. And cancer survivors, we also see that they had cancer survivors with cardiovascular disease, as you can see here, had the worst mortality compared to those with just cancer or with just cardiovascular disease. Looking specifically at early stage breast cancer survivors, we find that these patients also have increased mortality if they have heart disease, but a lot of their early mortality is dependent on the adjuvant therapy that's used over time. And in this particular paper, they looked at 45,000 breast cancer survivors, and of them, about 20% of them, about a fifth of them, had received adjuvant therapy, similar to the patient I had outlined earlier. And of the ones who had received adjuvant therapy, we notice what the therapy was. So here in light purple, we see anthracyclines. In slightly darker purple, we see the patients who received anthracycline plus anti-HER2 therapy like trastuzumab. And in darker purple are the patients who received both. Pretty early on, the anthracycline and trastuzumab were given concurrently, but that led to a lot of cardiotoxicity. So now the standard of care is, as mentioned, was shown in my patient, which is that the two therapies are given sequentially. And what we see here is that compared to early 2000 to now 2007, the proportion of patients who are receiving trastuzumab, either by itself or with anthracycline, has increased quite dramatically. They make up only about 3% of the patients who got adjuvant therapy, compared to about 23% here. And the same retrospective MASH cohort study showed that patients who received both anthracyclines and trastuzumab have more than twofold increased risk of developing heart failure or cardiomyopathy within 3 years. The next at high risk group are the ones who received trastuzumab alone, followed by the ones who received anthracycline alone. Switching gears a little bit and moving away from solid tumors, the other common group of patients that we see in our cardio-oncology clinics are the ones who are either about to undergo stem cell transplant, hematopoietic stem cell transplant, or the ones who've already undergone it. And this study by Eric Chow was done locally at Fred Hutch, and he shows that that patients who had the transplants had increased cardiovascular death, had increased ischemic heart disease, cardiomyopathy or heart failure, and stroke. And some of these differences you can start seeing pretty early on after their transplant. Some of the best long-term data that we have on risk of cardiovascular disease in cancer patients comes from, of course, childhood cancer survivorship data. In these studies, the patients are cancer survivors are compared to siblings who did not have cancer. And in this review, or this paper by Armstrong, they looked at the childhood cancer survivorship data and looked at cumulative incidence of coronary artery disease and valvular disease. And as shown here, patients who had received radiation therapy, of course, had far more risk of coronary disease than their siblings, but also compared to the ones who hadn't received any radiation, even those patients had increased risk of coronary disease compared to the sibling control cohort. Valvular disease, similarly, is most impacted by having in patients who had radiation therapy. Same with arrhythmia. And then when we look at heart failure, then we start looking at the cumulative effects also of anthracyclines. Patients who had received both radiation and anthracyclines had greater risk of developing heart failure than the ones who had either just received anthracycline alone or radiation alone. But even without the two combination therapies, even by themselves, they had higher risk of heart failure compared to the sibling controls. What they also showed in the same paper is that these patients, the childhood cancer survivors, have significantly higher risk for other comorbidities and risk factors that play a role in cardiovascular disease. This includes hypertension, dyslipidemia, diabetes, obesity, and if you have more than one risk factor, of course, it has a cumulative effect. And the important thing of note here is that they showed when you combine radiation therapy and hypertension in this patient population, the two risk factors potentiate the risk of developing major cardiac events beyond what you would anticipate by just additive, meaning it's more than what you would get if you just added the two risk ratios alone. And looking specifically at radiation, we look at a deeper dive because this is known to cause coronary artery disease and increased risk of it. And the risk increases with time, but this graph here points out that it is a very indolent process and occurs more than 10 years after treatment. And of course, the risk is higher with higher mean dose of radiation to the heart. Here, if the mean dose of radiation is greater than 25 grays compared to no radiation at all. But I want to point out that even with 1 to 14 grays of radiation, the risk is higher. And similarly, that was radiation in Hodgkin lymphoma patients from the childhood cancer survivorship data. But if you look at breast cancer survivors who've also received radiation, this was a landmark paper in New England Journal in early 2010, which showed patients from Sweden and Denmark, and it was a population-based case control study. And major coronary events, meaning MI, revascularization, or death from coronary disease occurred with increasing doses of mean radiation to the heart. But here it highlights that even with doses as low as 2 grays to the heart, the risk of coronary events increases, and you can start seeing these effects as soon as 3 years in this patient population. But I also want to point out that now with modern radiation techniques, and we're able to limit the dose to the heart quite significantly. And most of our breast cancer patients who do get left-sided radiation therapy tend to get less than 3 grays of mean heart dose. But ultimately, the point is that there is no such thing as a safe radiation dose. Eric Chow also did a review of patients who had cardiovascular disease and hypertension and other in a background of radiation or anthracycline therapy. And one last thing I wanted to point out from this is that, again, to highlight that the whole is greater than the sum of its parts. And what I mean by that is that hypertension, again, potentiates the risk of heart disease and heart failure. Increases or potentiates the effect of heart disease in patients who've received radiation therapy, and it potentiates the risk of heart failure in patients who receive anthracycline. but the total increased risk is more than if you just add up the two relative risks. This is true not just for hypertension, but also for dyslipidemia and diabetes. All of those risk factors potentiate the risk. So to summarize prevalence of cardiovascular disease in cancer survivors, we find that the best longitudinal data that we have is from childhood cancer survivors, where the 5-year survival is 83%, and from breast cancer survivors, where now we have increasing better therapies, and their 5-year survival is now 90%. Similarly, the best evidence that we have so far regarding cardiovascular toxicity from cancer therapies is from treating the above cohorts, mainly in the form of anthracyclines, radiation therapy, trastuzumab. There are many other cancer therapies that I'm not going to review here, but those are also associated with cardiotoxicity, and we've encountered all of those when we consult at UW Medicine, and we see these patients who've developed atrial fibrillation or pericardial effusion with other therapies. And I highlight some of those here, but there's a 2016 European ESC position paper on cancer treatments and cardiovascular toxicities. And if you're interested in this topic, they have a very good overview of some of the toxicities with other therapies. I also want to point out that cardiovascular disease and cancer share the same risk factors: hypertension, diabetes. All of those play a significant role in development of both of these disease processes and increase the risk for both of them. But even after adjusting for those risk factors, we find that cancer survivors have an overall increased risk of cardiovascular disease. And cardiotoxic therapies and typical cardiovascular risk factors that we discussed, as highlighted in the previous slide, their effects on risk of cardiovascular disease are more than additive. So ultimately, when we're evaluating a lot of these patients who've received these therapies, our standard ACC ASCVD risk calculator is unfortunately insufficient to determine their risk of developing cardiovascular disease. Instead, Eric Chow and his group developed these models to predict risk in childhood cancer survivors, and they validated these models in cohorts internationally. And so I provide a link over there, but it's essentially the Childhood Cancer Survivor Study Risk Calculator from the St. Jude website. And so if you see any patient who had a childhood cancer, had received radiation or anthracycline therapy, even if you don't know the dose of the radiation to the heart, or you don't know the dose of the anthracycline that they received, this is still a calculator that you can use because there are simple models that allow for that. Unfortunately, we don't have similar models and risk calculators for adult cancer survivors, though hopefully we're developing more data and developing these models with time. Switching gears a little bit and talking next about our imaging modalities and other modalities that we have for assessing cardiotoxicity in these patients. Here we see allogeneic hematopoietic stem cell transplant patients who were found to have decreased LV function after undergoing transplant therapy. Most of these cases were described as mild to moderate global hypokinesis with a few cases of valve disease. But I think one of the points that I just wanted to make is that, you know, there are many different modalities and different ways to assess LV dysfunction. And of course, the one that we use most often and we're most familiar with is EF. And traditionally we use 2D, Simpson biplane method of DISC to calculate EF. But now 3D is being more increasingly validated in this population. Historically, you'll see some papers that also use fractional shortening, but that's falling out of favor for various reasons. But there's also interest in looking at other ways of assessing LV dysfunction, including global longitudinal strain and mitral annular plane systolic excursion, essentially the E prime, the tissue Dopplers that we get. And regardless of how you assess LV dysfunction, what we find is that in stem cell transplant patients, they all have a decrease in LV function compared to the control group. And however, the question is, can we find patients who are at higher risk of decreased LV systolic function before their EF decreases? Meaning, is there a way to assess it subclinically and predict who are the ones who are going to develop that decrease in EF? And that's where strain comes in. So here we have 134 patients who were treated with anthracycline with or without radiotherapy. So this is in blue column is the entire group. In red, we have patients who received anthracycline plus radiotherapy. And in green, we have the group that received just anthracycline, but no radiotherapy. And as is expected, we find that the ones who received both therapies had increased risk of LV dysfunction in the form of drop in EF and fractional shortening. But a greater population proportion of patients had abnormal GLS. So for comparison, about 5 to 6% of the overall patients in the study had a drop in EF, but over a quarter of them had abnormal GLS, suggesting that these patients have subclinical cardiomyopathy that's present, but we don't know how it predicts their future outcomes. In this group developed this model in looking at breast cancer patients who are on trastuzumab. They evaluated got echo at baseline, at 6 months, and at 12 months, and defined cardiotoxicity as greater than or equal to 10% drop in EF. They also evaluated strain, and they found that global longitudinal strain at 6 months was the best predictor of subsequent decrease in EF, with an area under the curve here of 0.84. This was much better than if we used other measures of strain, including global circumferential strain or radial strain. But the question is, can we improve that sensitivity and specificity? And so there's meta-analysis looked at sensitivity and specificity as an early predictor of cardiotoxicity. And in general, what we find is that a relative decrease in strain by 10 to 15% may be predictive of cardiotoxicity. But if you add elevated troponin, a biomarker, to the abnormal strain, then certainly our sensitivity decreases, but our specificity for predicting who's going to develop heart failure or significant cardiomyopathy, that specificity for measuring that increases. What about cardiac MRI? It's our gold standard for evaluating LV size and ejection fraction when echo is inadequate. But it can provide us a lot more information than LV function. It can tell us about myocardial scar, edema, fibrosis. And one of the most important metrics that has come out is extracellular volume, which is a marker for subclinical fibrosis. So, and that's true in both adult cancer survivors and childhood cancer survivivors. Here we see that adult cancer patients who received anthracycline had increased extracellular volume compared to those who are still awaiting their chemotherapy. And of course, that difference was even greater compared to control patients who did not have cancer. In childhood cancers survivors, we see, again, similarly, patients who had received anthracycline and they had increased extracellular volume by cardiac MRI than the control group. And I wanted to move on to talking about biomarkers and whether they can be used to assess cardiotoxicity. I briefly mentioned troponin earlier, that it provides this additive information when combined with strain. And what we see is that in these patients who are treated with either anthracycline, trastuzumab, or both, increasing troponin and BNP up here tends to predict decreases in EF. However, this association was really only significant for BNP. Here. There's a wonderful article in JACC recently in last year that takes a review of several classic hallmarks of cancer. And we find that cardiovascular disease and cancer share common pathophysiologic mechanisms. And some of those mechanisms are highlighted here. They include inflammation, cellular proliferation, resistance to cell death, neurohormonal stress, which we're all familiar with, angiogenesis, and genomic instability. There are some of these markers that have been developed to assess those mechanistic links, and those are still under study and whether they can be used to inform diagnosis, prognosis, therapy across both of these diseases, and really highlight and explore the link between the two processes. To summarize the diagnostic tools that are currently available for us for assessing cardiotoxicity, this is a summary from the 2016 EACI position paper. And it highlights that we can use echo, 2D, 3D, or strain. MUGA scans, I'm not really going to talk about, but they're useful primarily for giving us a reproducible measurement of EF. But also cardiac MRI, of course, the downside to cardiac MRI is that they're not available widely, are expensive, and patients quite often run into things like claustrophobia. And of course, Biomarkers and their role in predicting cardiovascular disease is still a burgeoning aspect and burgeoning field. And the point that I wanted to make here is the advantages to echo and biomarkers is that they're widely available. With echo, of course, the issue is reproducibility and inter-observer variability. Our ability to get accurate measurements of strain are first of all dependent on image quality. As I mentioned, the patient that I had presented at the beginning of the talk, she had suboptimal endocardial definition, so we could not reliably measure her strain. But also one of the other big problems with global longitudinal strain is there's inter-vendor variability. We've gotten around it recently at University of Washington with the TomTech software, which gives us the ability to do offline GLS measurements, regardless of where we got the echo images from which echo machine. And I've had an opportunity to use it a few times, and it's really a powerful tool. The next part of my talk is going to highlight some of the management strategies that we have for cardiovascular disease in cancer patients. And the main one that we have is Dexrazoxane in preventing or providing cardioprotection for patients who receive anthracycline. Data for cardioprotection for these with Dexrazoxane has existed as far back as 1998. But it has not been widely used because there is concern that it's going to impact the anti-tumor efficacy of the chemotherapy or increase the risk of secondary tumors from it. And here finally we have a wonderful meta-analysis that was in JACC Cardio-Oncology in 2019. And it shows that Dexrazoxane is effective in reducing risk of both clinical heart failure and cardiac events overall. Now, this is just looking at breast cancer patients who are treated with anthracyclines, but it's a pretty powerful evidence that we have a protective tool, and it's most effectively used in patients who are at higher risk for cardiomyopathy. So for example, women who received anthracycline doses greater than 250 milligrams per meter squared. In order to address the concerns about anti-tumor efficacy, they also looked at the oncologic response to anthracyclines. And what they find is that Dexrazoxane does not have any impact on the overall survival or progression-free survival of these patients, meaning that the anti-tumor efficacy of the chemotherapies is preserved and not adversely impacted by using dexrazoxane. What about neurohormonal blockade? There's been a lot of trials that have tried to answer this question. Our best data, of course, on this comes from non-cancer patients, and that data informs our heart failure guidelines and the goal-directed medical therapy that we use with either beta blockers and addition of ACE inhibitors and ARBs. But the results in cancer patients for primary prevention of cardiotoxicity from, say, anthracycline or trastuzumab, that's been rather inconsistent, partly because the trials have been very small or single trials, very few centers. There's been some heterogeneity in how the treatment effect is estimated, and it's unclear whether these trials are done for, or these studies are looking at short periods of time, and unclear whether we have data on long-term EF prediction. But this meta-analysis evaluated 17 studies, and it does show that about 4% absolute attenuation in LVEF decline with neurohormonal blockade. Now that's a rather small effect size, but it's significant. And I think we're going to need more larger randomized control trials that are adequately powered to be able to really answer this question about treatment effect on clinical outcomes. There are additional cardioprotection studies that are still ongoing and pending results, including statins and whether they can attenuate drops in EF. And they're looking at patients primarily, again, anthracycline is a big culprit in developing cardiomyopathy in cancer patients. So most of these studies look at that, but also looking at trastuzumab. And we have one study also evaluating effects of tyrosine kinase inhibitors on EF. But again, the outcome measures are within short term, up to 3 years. But hopefully they will inform some of the more data on whether we can use neurohormonal blockade for primary prevention. What about secondary prevention? Meaning patients who've received anthracyclines or trastuzumab and have developed asymptomatic LV dysfunction. The historically and traditionally standard of care is that once there is a small decline in EF, even if patients are asymptomatic, to stop trastuzumab. But unfortunately, that puts the patient at risk of adverse cancer outcomes. Baseline decrease in EF across different studies, particularly with anti-HER2 therapy like trastuzumab, the estimates of how much the EF declines is varied from 3 to 27% in these patients. That's a large chunk of population with HER2 positive cancers who are not getting the optimum therapy that they need. So there were a couple of trials that looked at really small pilot studies that looked at whether these patients who do develop asymptomatic declines in EF, whether we can continue giving them the anti-HER2 therapy if we give them cardioprotection. So this was a Safe Heart trial, and here it outlines the methods that they used. And it really is a prospective pilot study, 30 patients. This data was published in 2019, where they had stage 1 to 4 HER2 positive breast cancer patients who were candidates for HER2 blocker therapy. And they had a decline in EF, but EF stayed between 40 to 49%, not below 40%. And they did not have any symptoms of heart failure. They chose to continue anti-HER2 therapy in these 30 patients, but start them on carvedilol and ramipril and up-titrate the dose at the schedule that was given here. So very controlled titration of medications. They monitored heart rate, blood pressure, and some patients weren't able to achieve the goal, but a majority of them were. And they were really looking at how many of these patients, if we continued trastuzumab in them, how many of them had a further decline in EF to below 40% or had symptomatic heart failure. And here they find out that 30 patients, majority of them did not have any cardiovascular events. 2 patients did have a decline in EF or symptomatic heart failure. And 1 patient had a further decline in, sorry, let me correct that. 2 patients had symptomatic heart failure, whereas 1 patient had a further decline in EF and below 40%, and therapy had to be stopped. So overall, about 10% of the patients who were continued on trastuzumab had clinical outcomes if they were continued on goal-directed medical therapy. There was another similar prospective study, the SCHOLAR trial, which answered a very similar question: what if anti-HER2 therapy was continued despite low EF? And here we had about 20 patients, again, very small pilot study, phase 1, where they had an EF of 40 to 50%, or 40 to 54%, or greater than 15% drop in EF. And they were started on beta blockers and ACE and ARBs, but the doses and the drug of choice was left up to the primary provider. And the goal here was to let most of these patients continue to get, again, their trastuzumab or related anti-HER2 therapy. And they were, most of these patients were scheduled for 18 doses total of trastuzumab. And as you can see here, majority of them made it. This was the blue highlights the number of doses that they got before they had a asymptomatic decline in EF when they were started on goal-directed medical therapy. And then the red is after they were enrolled in this trial. And majority of them were able to make it to the 18 scheduled doses. This patient had only 17 scheduled doses. But again, of the 20 patients, there were 2 who had were unable to finish their treatment plan because of worsening EF. So again, 10% decline in cardiovascular, in worsening cardiovascular cardiomyopathy, which is very similar to the SAFE-HEART data. The caveat, of course, is that the SAFE-HEART and SCHOLAR trials are both single-arm studies, and we definitely need more long-term randomized controlled trials that inform our secondary prevention strategies. And of note, the SCHOLAR study trial also showed that the decline in EF that happened at enrollment, for the most of the patients, with the 2 exceptions, tended to stay stable, but it did not improve to the pre-treatment levels. So there's some level of concern of irreversible cardiomyopathy, but only longitudinal data is going to answer those questions. This is a very important trial, and including combined with the SAFE-HEART trial, so much so that when JACC Cardio-Oncology, the journal, was launched in 2019, this was the very first article in that journal. What are the current guidelines on cardiovascular assessment and management in cancer patients? This is a tough question to answer because there's a lot of options for us. And they vary, of course, whether they address childhood cancers or adult cancers. And some of them just focus on imaging evaluation and how to surveil these patients over a long time, versus in developing recommendations on management of these patients, versus looking at just biomarker recommendations. There's been some attempts to reconcile different guidelines. So for example, there was a 2020 French consensus article that tried to find a common pathway between American and European guidelines on this. And some are just restricted not to overall cancer therapies, but really just to anthracyclines plus minus trastuzumab, because again, that's what we have the most data on. This list of guidelines, of course, does not include all the other ACC, AHA guidelines that we're all familiar with. And in some of these guidelines do highlight that in the absence of data specific to cancer patients, we end up relying on those guidelines that are applicable to the general population and hope that they work in this patient population also. The main thing I want to highlight, I've pointed out a few different times, is that the 2016 EACI position paper is a very good resource for looking at different cardiotoxicities of cancer therapies, including particularly the ones that I don't mention or don't go over in this talk. And it has a good overview of management strategies. So if anybody's curious, I highly recommend that paper. A few things that I wanted to highlight, particularly about surveillance and imaging. This was a 2014 ASE guideline and European Association of Cardiovascular Imaging guideline on how to do surveillance in patients who receive anthracycline. And they recommend for patients who tend to have normal EF and normal strain, or at least above the lower limit of normal. For these patients, you should also get a troponin. And if that's negative, then do a baseline echo before therapy, and then do one at completion of therapy and another echo 6 months later. If somebody is getting trastuzumab or anti-HER2 therapy, then the recommendation is to get echo every 3 months while they're getting the therapy, and then again one at the end. Combination of the two, as I mentioned, that in breast cancer patients in particular, the adjuvant therapy is given sequentially. So generally they get anthracycline first, followed by trastuzumab. And if that's the case, for these patients, the recommendation is to do echo at baseline every 3 months, and then at the completion of therapy, and again 6 months later, to combine the two surveillance guidelines for the two different therapies. And in all cases, if there is any relative decline in EF or longitudinal strain, or if they have a positive troponin, the recommendation is to consult cardiology to potentially initiate them on goal-directed medical therapy. This is a little bit different from the childhood oncology group recommendations. They were updated in 2018, but in general, they focus not on trastuzumab, but on combination of radiation and anthracycline therapies. And they recommend doing an echo every 2 to 5 years, depending on what their overall risk is of developing cardiomyopathy. Interestingly, 2016 American Society of Clinical Oncology, their guidelines are very comprehensive. They go from risk stratification of patients to evaluating them before therapy, during therapy, and long-term surveillance. But they make a point that there are no recommendations really that can be made regarding continuation or discontinuation of cancer therapy if somebody does have a decline in cardiac function or develops a cardiotoxicity. There's no simple answer of, oh, they developed a drop in EF, or they developed a small pericardial effusion, we should stop whatever the cancer drug is or treatment is that's causing that problem. Partly because of adverse oncologic outcomes, and really it just needs to be a joint decision between the oncologist, the patient, and the cardiologist, and frequent and close monitoring, which leads to their second recommendation, which is the frequency of cardiac imaging for each patient is determined on an individual basis and on their individual patient circumstances and the clinical judgment of the providers taking care of the patient. So unlike the previous guidelines, they really do not recommend surveillance every so often. There's a lot of guidelines on echo surveillance in general, and this highlights all of them. And the point isn't to read every single one of them, but the point is that there is no strong evidence actually to support a specific schedule of screening or any evidence that screening these patients actually prevents long-term cardiomyopathies and clinical outcomes. However, despite that lack of evidence, Screening every 3 months is recommended by FDA, but that frequency of how often we do the screening is controversial, and compliance with that screening schedule is actually rather limited. And the last thing I kind of wanted to point out in this section about guidelines is a point here made by the National Comprehensive Cancer Network 2020 guidelines, which make the point that, again, there's not enough data available to define cardiovascular disease risk groups among cancer survivors. We have some modeling, as I highlighted earlier, in children, but not really in adults. And but the current tools that, again, we have do not take into account cancer treatment history and do not accurately capture true cardiovascular risk in a given survivor, in a given cancer survivor. What are future directions? Where are we going in cardio-oncology as a field? Part of it is making cancer therapies that are less cardiotoxic. For example, radiation with proton versus photon therapy. Photon therapy is the traditional radiotherapy that's used, but now we're trying to use proton therapy because it's less toxic to native organs and cell tissues and more targeted towards cancer cells. This is a RAID-COMPS study, and we are part of the main study and an ancillary study that looks at biomarkers with radiation with proton versus photon. There's also a need for an ongoing longitudinal studies in adult onset cancer survivors with refinement of risk prediction models. We need more, well, maybe not more, but we need better evidence-based guidelines that also consider cost effectiveness. As I mentioned previously, the FDA still recommends doing an echo every 3 months in patients receiving trastuzumab, but is it cost effective? No. For childhood cancer survivors, they get an echo every 5 years. Is it cost effective? No. So we need a better way of better finessing the patients who are at risk and really developing those guidelines a little bit better. And we need more studies on secondary prevention. As I mentioned, most of the data is from the general population, not the cancer population. And we need larger randomized control trials that do longer follow-up, similar to the SAFEGUARD and SCHOLAR trial, that shows us whether we can continue certain cancer therapies while protecting these patients from cardiovascular outcomes. And assessment of cardiotoxicities from novel cancer treatments, such as immune checkpoint inhibitors or chimeric antigen receptor T cells. These are very interesting and ways of addressing cancer and treating cancer. But as we know, some of the ICIs can cause myocarditis. The CAR T cells can cause a cytokine release syndrome, which is associated with adverse cardiac outcomes. So we need a better definition of, again, who's at risk and whether how we can minimize that risk. There's also novel treatment strategies. There's really not a lot in terms of tertiary care of patients who, once they do develop symptomatic heart failure, what do we do about them? And this is so interesting where very recently there was a pilot paper on doing injection of mesenchymal cell therapy, stem cell therapy, into patients who develop symptomatic heart failure. And again, it was a very phase 1 safety trial that showed that doing these MCT injections are safe. It wasn't powered to show outcomes, but there is some improvement in markers like EF and 6-minute walk time. And so it's very promising how we can help these patients. And one last thing that I wanted to mention is cardio-oncology is a growing, burgeoning field, and we need more people in it. And Richard's been very crucial part of a group of individuals for developing an education and training plan for this to become its own robust subspecialty. And there's two pathways into it, either from the cardiology side or the hematology oncology side. And whichever path you come from, there is knowledge you need from both sides. So if you're a cardiologist like myself, there's been a pretty steep learning curve on learning principles of cancer biology and treatment approaches, how to manage malignancies, chemotherapies, targeted therapies, radiation therapies, survivorship data. And that's the kind of the gaping hole that needs to be filled for patients or for providers coming from the cardiac side. Whereas from the hematology side, these are the providers who need to learn a little bit more about principles of cardiac pathophysiology, or diagnostic tools, how to manage and provide prognosis for these patients, and knowing which subspecialties to approach for other management. To circle back to my patient that I saw in clinic, based on the Safe Heart and Scholar trial, we decided to start her on maximal doses of carvedilol and losartan. Her EF had already improved by the time I saw her, partly because she had temporarily stopped her trastuzumab and she had already finished anthracycline. But after seeing me, she was started back on it, and she was on this goal-directed medical therapy. She underwent successful mastectomy, and her EF continued to be in the 50s, not quite where it was back pre-treatment, but still better than where it was right here. Okay. Thank you so much for your attention, and a big thank you to Richard for getting me involved in the field and talking to me and teaching me and educating me about this. It's been a very exciting journey for me.